Thanks for the GulfPCR and for Ricord to arrange this short symposium about what we believe is an essential and emerging line of therapy that actually need to be discussed, and we need to understand the need of the operators and where we can move forward with developing therapies to treat some of the most serious medical conditions that we face in our society, in our community. Today, the whole session is about renal denervation, but I'm pleased to have a group of, as I say, known interventional cardiologists in the region and internationally. So we have Dr. Andrew Sharp from UK. He's going to give us a good brief about the therapy and the update of the evidence and where do we stand. We have Dr. Hussam Noor from Bahrain, Dr. Fahad Basalib, and Dr. Arif Noorani from United Arab Emirates. They are renowned interventional cardiologists in the region. And of course, last and not least, Dr. Imad Haddad, who is one of the senior interventional cardiologists in Jordan. These guys are sort of a believer on the therapy, okay? And they are here to tell us and show us why they are believers on the therapy. And it's important that we all be on the same page, because it's very important that we understand what's the issue that we're facing and how we're going to face it, and where is the evidence stand for, so we know where we're going, because that's very important for the next step. So the session today will be focused on, number one, is to understand the clinical need to treat hypertension in the Gulf region. And I'm pretty sure it's not really a big difference from the entire globe, but we have some unique demographic characters that maybe make hypertension also a very serious disease that we have to face in this part of the world. We want to understand and learn what's the latest clinical evidence, guidelines, and technology for renal denervation, discuss the clinical experience with ultrasound renal denervation, which is a very interesting and intriguing concept that now is emerging and has a clear FDA approval as a standard therapy for renal denervation, and how to practically select patients, which is, we learned over the last, I've been doing renal denervation for 11 years, and I learned over the last years how to select my patients. Of course, not we over the first few years, we were able to understand who's the responders from not. So we have what I'm doing now is the welcome and introduction. This is a quick agenda. I'm going to explain to you what are the unmet needs, just to set the ground for the future discussion and why we need to think of renal denervation. And then Dr. Andrew Sharp will talk about, ready for the prime time, we'll open for discussion. And before I start, I really want to see how many of you will consider renal denervation today as a therapy for hypertension patient? Just a show of hand. 1, 2, 3. Okay. I hope at the end of the session we'll have more hands. Anyhow, all right. So I'm going to start with the first presentation. I'm Dr. Mohammed Kurdi. I'm an interventional cardiologist. I'm the ex-president of the Saudi Interventional Society. I have no conflict of interest. Currently, I'm a CEO for a Brocare hospital, a 100-bed hospital in the eastern province of Saudi Arabia, and I'm still practicing interventional cardiology. What does it mean to have an unmet therapy? It means that it's a kind of therapy or an intervention that does not fulfill the expectation of the patient benefit and care. So if you have a therapy and you still have a gap and you're trying to do the management of the patient and you still have a gap, so you are not really fulfilling what you should be doing. And When we talk about hypertension, it's very important to understand why we talk about hypertension, because hypertension is really a global issue, and it's a big challenge because hypertension is considered one of the main reasons for morbidity and mortality in the global societies. 20% of the death in worldwide related to hypertension. And there is a lot of complication that we see day after day with resistant or uncontrolled hypertension. I'm going to try to go through these factors, and I'm going to use some statements like WHO, who said hypertension is a silent, invisible killer that rarely causes symptoms. And here is the big challenge, that we people do not come complaining of hypertension. They get caught having a high blood pressure on their routine visits, or sometimes going for another reasons. So hypertension is a problem that we are not diagnosing properly. Increasing public awareness is a key, as it's the access to early detection. Raised blood pressure is a serious warning sign that significant lifestyle changes are urgently needed. People need to know why raised blood pressure is dangerous and how to take steps to control it. Of course, what's the definition of optimal hypertension? 120/30, but you really want to reach a target, you try to minimize the complication, which is less than an average of 135 or 140 in the visit office. According to the CDC, in the United States, there is 1 out of 3 Americans is hypertensive. Globally, there is 1 billion people are suffering with hypertension. By 2025, which is the last paragraph, which is very close, it's just around the corner, you're going to have 1.5 billion people, accounting for 30% of the world population, would be hypertensive, with 75% of these from the developing countries and region, which is very serious. You're talking about 1.5 billion of the population of the globe having hypertension. So 20% developed countries, 80% in the developing nations. The highest prevalence will be developing countries like Asia, Africa, will account for the 75%. If you look at the control, prevalence and control of hypertension, if you go around the globe, only 13% of the 1.5 billion will be actually controlled by definition of control. And of course, men are worse in being controlled than women. And the high-income countries, 28%, while the low-income countries, only 7.7%, which constitute to the most part of the globe. The adherence to life medication is the issue. That's one of the very important issues, that we are not controlling them because they are not adhering to medication. 44% were partially non-adherent in one of the major trials published in Hypertension Journal. The adherence is also dynamic. So if you actually give medication to your patient and you think, oh great, I caught that patient, I started him on therapy. Actually, this will change over time, and adherence is related to the number of medications. And 75% of patients, they need more than 2 medications. And by this, the highest the number of medications, the more likely they're not going to get adherent to the medication, and the most likely they're not going to get control. So why important to be adherent and why important to control? Because adherence translates into reduced cardiovascular events. And the lower the adherence, the higher the complication, and vice versa. So adherence is important, and it's variable, and people do not prefer medications. There is a lot of people that actually would prefer that if there is another therapy or another way of therapy, that they can avoid these multi-pills that they need to take every day. Hypertension is variable. Hypertension, and I always tell my patients, he said, my cousin has hypertension. I said, each one of you is different. Each patient is different, and this is why you need to listen to them, take a proper history, do a proper physical examination, and proper investigation to be able to define what kind of hypertensive patient that you're dealing with. Because if you do not define them, you cannot select them, and you cannot select the type of therapy. So you need actually to spend more time in history, which is very problematic in a system where you have 30 or 40 patients booked in your clinic. And you need to have a proper physical examination and examine them properly and do a proper investigation. And it's a long list of investigation that you have always to be aware of, that most of the time, lots of physicians are not actually doing it because of the sake of time, because of the limited resources in the developing countries, and because of the patient being not convinced that I'm going to come back and do these investigations. Treating hypertension, the goal is we all know and we target less than 140. What's most important is what is the benefit of treating hypertension, and that has to be told to the patient. That, listen, your chance of reducing your chance of having a stroke is going to be lowered by 40% if you stick to your medication. You need to be aware that your chance of having a heart attack is 25% lower. You need to be very precise to your patient about treatment of hypertension and why we're treating hypertension. And usually what I do with my patient is I start with saying, do you know why we need to treat hypertension? And he'll say, well, it's a disease. I say, no, you need to know why. I'm really concerned about your blood pressure, and I want to treat it because it's me and you that are going to treat it. I play a 20% role in treatment of hypertension. The patient plays the 80% role in treating hypertension. So I always say reduction of heart failure is one of the major things that we've seen with proper treatment. And heart failure is a growing epidemic across the entire globe. Multiple management methodology, non-pharmacological or pharmacological. At the end of the day, you need to continue doing the weight reduction, adopting the low salt, the dash salt, the erythropoietin. So here is that, and I always say that to my patient, I don't think we have given hypertension its own prestige. Hypertension is a disease that needs a dedicated clinic with a dedicated team. We have given diabetes more attention than we've given hypertension. But I think we should give them both. And there should be a dedicated team to look after hypertension. And hypertensive patients should go at least once a year through that clinic for a proper assessment and proper therapy, because we need to be on top of all the other small factors that can control and help in reduction of hypertension. It's not a single therapy. One of the problems of the RDN in the initial phases, we all thought this is the magic bullet that actually going to give you the treatment and patient will be out next day. That's not true. It's going to be supportive. It's going to be reducing blood pressure. It's going to reduce mortality. It's going to reduce morbidity. But it's not the only modality that you should depend on, and patient can go and do whatever he wants. The hypertension in the GCC region, it's not different. I have a Saudi meta-analysis that looked at all the data and publication which was published in Saudi population across hypertension. Only 29 papers which actually fit the criteria from the database, and clearly shown that there is a major issue. 40% of the population is only aware of hypertension. 60% of the population, they are not aware about hypertension. They don't know what is hypertension. And its other problem is that even those people who are actually aware, the majority, or half of them are not treated, and the other half is treated, but they're not controlled. When they've screened everybody and they go into the schedule of who's screened, who's diagnosed, who's treated, who's controlled, only 9%. 9 to 10%, it's the global number. I just showed you the first slide. 13% globally are controlled. In the developing countries, 7% is controlled of hypertensive patients. So if I have 100 patients today, only 7 of them are controlled. That's a very low number for any modality that we think we are treating and we are happy. And we have to change the concept in the mind people, because we need to talk to them about it. Because people come to my clinic and say, you know what, it's my blood pressure. It's always 150. This is my blood pressure. Don't worry about it. I say there's nothing called your blood pressure. There is a normal blood pressure and you have to be within the target. No, it's my, I said no. So people need to be aware that only 9% in the Gulf region is actually controlled. So where is the unmet need or challenges that we have in treatment of hypertension? I think at all levels, at screening level, access to the health facility, reaching people to their own homes, doing screening and diagnosing them. And in 2008, I've done a campaign. I went in Riyadh across all malls, and I created a portable clinic. And I diagnosed 38% of the normal people who actually walks around in the mall. They have high blood pressure, higher than 140. 38% are hypertensive, and they are not diagnosed. Out of 5,000 population that I screen. Diagnosis in the office is always a challenge, and you need to give time, and you need to sit people, you need to do the home monitoring, you need to follow them up, you need them to come in a close follow-up. You need really to have a proper diagnosis, and that's a problem because it's one of the gaps that we need to fill. Treatment, of course, you need to empower your patient, and you need only 25% of these people have been treated. Adherence, of course, and you see control is less than 10%. Follow-up and the continuous follow-up and continuous monitoring of the subgroups that actually need special therapy, renal patients, diabetic patients. These are people we need more aggressive therapy. This is just an introduction. I guess Dr. Sharp has more to say. We'll move to the next presentation, and Dr. Sharp, please.
Thanks very much, Dr. Kurdi. That's a great introduction to the problem of hypertension. So I usually start these talks by pointing out that hypertension is the most important disease in medicine. And that usually wakes a couple of people up because it sounds controversial, right? There's lots of important diseases. But hypertension is the #1 cause of avoidable death in the world. And it's easily treatable. It causes more deaths in 2020 than COVID did. So the world transformed itself to deal with COVID during 2020, the worst year of the pandemic. And it poured resources and medical time and hospital beds, and it transformed its healthcare systems to deal with this new pandemic problem. And in doing so, fewer people died of hypertension-related diseases that year. So we've got a COVID's worth of disease happening every year for the last 100 years, and we don't have enough doctors or equipment to manage it. So that's what hypertension devices are about. So I will try and convince you that not only should you get involved, we need you to get involved. Okay, so I'll just follow on from some of the statistics that Dr. Kurdi showed. So this is a study of metabolic risk factors in North Africa and the Middle East over the last 30 years. Which of these risk factors caused the most death in the region in 2019? High systolic blood pressure, high BMI, high fasting glucose, so again, the diabetes story, or high LDL, right? You open any newspaper, you turn on any TV, in many countries in the world, all you see are adverts for LDL management, and that's right. We need LDL managed. So I won't get you to put your hands up because I think I've given you the answer already. This is the results. High systolic blood pressure caused 803,000 deaths across all age groups and had the highest number of attributable deaths in 2019. So this isn't 2005, this is 2019. And it caused double the amount of deaths related to LDL. So when you spend hours focusing on statins and PCSK9 inhibitors and ezetimibe and all these things, just remember that doubling the perindopril is probably more important than adding a PCSK9 inhibitor. And it's really simple to do. And if you look at these bars, you don't need to look at the detail on the numbers, just look at the colors. Because the blue bars are 1990, and these are years lost to hypertension. right? These are healthy years lost to hypertension. You can see the blue bars are higher in the top left-hand graph, which is hypertension, than it is in the other three, which is basically diabetes, obesity, and high LDL. And you can see there's very little difference in 30 years. We haven't been able to bring blood pressure down as a cause of lost years of life in the Gulf and North African region for 30 years. So we have more than enough tablets. It takes about 3 tablets to manage 90% of the population. If they take those 3 tablets, their blood pressure will be controlled. So we know how to do it. And yet, for the last 30 years, we haven't been able to do it. And my country's worse than this. So this isn't a criticism. This is the same across the world. And these are the global statistics. So about 1.4 billion people have high blood pressure. About half of them know about it. So we've got to start screening people. We've got to start opportunistically taking blood pressure. The onset in this region is younger than it is in many places in the world. So we need to start thinking younger with hypertension. Of those, about 3/4 to 2/3 are treated, and of those, less than half are controlled. So it's a tiny number who are controlled. And we've seen this graph before, that these are patients coming to hospitals and being investigated in clinical trials. So these are motivated patients because they're in a hospital being studied. And yet, almost half of them are not taking all of the medicines prescribed for hypertension. Now, I'm sorry about the size of these numbers. I've learned from years of running a hypertension clinic and studying hypertension that they try and put the numbers as small as they possibly can. So you'll see that on the next 2 slides. I think everyone must have telescopic eyes. But this is a meta-analysis of the effect size of one antihypertensive drug. And as doctors, many of us think that they're more powerful than this. And the reason is we start an antihypertensive drug when the blood pressure is high. And so the natural oscillation suggests that the next reading will probably be lower. More often than not, it'll be lower the next time because there's a natural oscillation in blood pressure. And so when we give a drug and they come back and it's 30 points lower, we think, my goodness, this amlodipine is amazing. But what's happened is there's a natural oscillation, and amlodipine has taken 9 points off that blood pressure. Thiazide 11, beta blocker 12, and so on. So the average effect size of a single drug is about 12 millimeters of mercury. What happens when you give a combination drug, 2 drugs? So here, again, tiny little numbers, I apologize, but you get a systolic blood pressure reduction of 20 from 2 antihypertensive drugs. So that's the effect size of a double pill. So drug 1 is 12, drug 2 is 8. What about when you get out even to drug 4? We did a study of this in the UK. Patients who were already on the 3 standard drugs you would use for hypertension, and then we rotated them through placebo, spironolactone, bisoprolol, doxazosin, and we saw which one was the most powerful on home blood pressure. And if you look here, the placebo effect was 4 points. So when you subtract that, what do you get from drug 4? You get 8 points from spironolactone and 4 points from an alpha blocker and 4 points from a beta blocker. So drugs are great to begin with. But as you give more drugs, they get less powerful, and they have more side effects, and patients become more non-adherent, as Dr. Kurdi showed you in that graph of the increasing non-adherence in patients as you give them more and more drugs. What about salt reduction? There's a reason why I'm going through this. If you bear with me, when I come to renal denervation, you'll understand. This is a Cochrane analysis, supposedly the highest standard of evidence of salt reduction. I'll blow up the bit that matters. Although it's a white population, it's the same everywhere except the Far East. What is the effect of a salt reduction program from high salt to low salt? It reduces blood pressure by 5 points. Now that's important. We strongly encourage it, but it's 5 points. Okay, so hold that thought. So why are people recommending these things? The answer is a very small change in blood pressure has an incredibly important outcome for your patients if they have hypertension. These are the so-called floating curves, where what you see, hopefully this comes up, it won't. Does it come up on here? Yeah, great. What you see here is a curve according to decile of age. So you can see if you are in your 50s and your blood pressure is 120 and it goes up to 180, your risk of stroke rises by about 20-fold. An enormous increase in risk. For heart attack, the curves are a bit flatter, but it goes from 1 to 10-fold if you're between 40 and 49. So high blood pressure is driving heart attacks and strokes in an incredibly powerful way. And that's why if we reduce blood pressure by 2 millimeters of mercury, We reduced the risk of stroke death in middle-aged people by 10% and heart attack by 7%. Now, anybody here use ticagrelor? Ticagrelor reduces the event rate in ACS patients by using it instead of clopidogrel by 13%. 13%. So to get the same outcome benefit, which is not mortality, by the way, it's not 13% mortality, all you have to do is lower blood pressure by about 2.2 points. And you can do that much more easily. So we've had more than enough drugs, so what's going on? Can we do something else? What about sympathetic nervous system neuromodulation? Sounds fancy. So years ago, about 100 years ago, an American surgeon was doing an operation on the retroperitoneum, and he accidentally cut the nerves to the splanchnic bed. And a patient who had a blood pressure of 300 systolic, because they had no drugs back then 100 years ago, found that their blood pressure came right down. So they started doing this operation, where they went in and cut the nerves to the splanchnic bed. Now the problem is, those nerves were supplying all sorts of important things, like the bladder and the bowel and the sexual organs and so on. But by doing so, by cutting the sympathetic nervous system component of that bundle, they caused significant drops in blood pressure, and there were thousands of procedures done. You can see here this case series. Like, we wouldn't call this a case series, we would call this a lot more, but 1,266 cases. So this was a very serious surgical procedure that was done for high blood pressure a long time ago. But when drugs came along, it went out of the way. But this is the sort of thing they used to produce in 1948. This is a patient who had onset of hypertension 3 years previously, toxemia of pregnancy, severe headache, nausea, vomiting, blurred vision, incapacitation, confined to bed, because her blood pressure was 280. And with no drugs, they couldn't do anything about it. So this lady underwent an operation, and she had a transformative effect on blood pressure. Now, not all of the operations work that way, but in this case, it did. Okay? But when drugs came, it went away because the side effects were bad. They were cutting all sorts of important nerves. And we thought we had enough, because we've got these 20-odd drugs that we can use for hypertension. And we know that if you put 3 of them together, then the patients will do well. So it all went away. But about 15 years ago, people realized that drugs aren't enough. Why? Because patients aren't taking them. We offer, and they say no. They do it covertly or they do it overtly. So we've decided to go back to devices, and this time targeting the renal bed. So why the renal bed and not the splanchnic bed? Because that was what the surgeons used to do. Well, the answer is we have a working human model of kidneys working without any nerves. Because if you have a renal transplant, the new kidney goes in without any nerves attached to it. So we know kidneys can work without nerves. So that reassured us at the beginning about safety. And the second thing is that there's nothing else that those nerves are going to. So unlike the splanchnic bundle, which was going to all sorts of important organs, the nerves to the kidneys are going to the kidneys. Okay, so if we sever them, we know we're just disconnecting them in a way that anyone with a transplant kidney is using. So how do we do it with the ReCore technology? This is an ultrasound technology. So what it does is it emits from an ultrasound device a 360 circle of ultrasound out into the periadventitial space, the fat that sits around the renal arteries. And it heats those nerves until it kills them off, until it ablates them. And then it permanently disconnects the nerves that run between the brain and the kidney and back again. It also has this interesting facet where it runs cool water through the balloon and back out again. So it's connected to a bag of water that sits outside of the body, and a machine runs the water through the balloon to cool the endothelium. And that way, the energy that goes out and heats the nerves does not heat the endothelium, and therefore the endothelium recovers fully. But what this means is you get denervation occurring between 1 and 6 millimeter depth. So that's a different characteristic of ablation than we get with the radiofrequency devices that we've had before in this space. So here you see on the left the first sonication that's delivered. This is a ring of ultrasound creating heat and ablating the gel that sits all around the renal artery and therefore destroying the renal nerves. Here we have a second one, and you can see when you're looking down this sparing that occurs because of the cooling effect of the balloon on the near field. This increases the safety profile and means that you can be reassured that your patients are going to heal nicely. So that's all very well in gel. What about in humans? So the 3 main clinical trials that have been run by this program were Radiance Solo and Radiance 2, which were off-med trials. I'll tell you about that in a second. And then there was an on-medication, a resistant hypertension trial called Radiance Trio. And essentially what we did was we tried to standardize the blood pressure of patients who had to have combined hypertension, systolic and diastolic. And it had to be between 140, and 180 on office, and then it had to be abnormal on ambulatory blood pressure, so to make sure we don't have white coat hypertension. And these were 3 separate trials run at 3 separate times by groups around the world. And this is the headline. So what did it do? It did about the same as a single drug across the board on average. Okay, 1 drug's worth of antihypertensive intervention. Although it has to be said, this is ambulatory blood pressure. So about 8 millimeters of ambulatory blood pressure reduction. As we know, office blood pressure is slightly weaker in its predictive powers than ambulatory. So ambulatory is more potent for every millimeter reduction. And the sham effect was very small. We then put these together on a patient-level basis and looked at the different ways of looking at blood pressure reductions. And we're seeing 8 millimeters to 7 on daytime, nighttime, and home. And then on office, it's more like 10, 10.5. So for that, we would expect to get around about a 28% reduction in stroke, 27% reduction in heart failure, 20% reduction in MACE if this was achieved with any other mechanism, whether it be lifestyle or drugs. And when I tell people this, the question that most often comes at the end is, yeah, but HTN3, right? So Simplicity HTN3 was a major trial run and reported in 2014. It used the radiofrequency device, not this device, and it was in resistant hypertension patients on 5 drugs. Now, as Dr. Kurdi showed you, if you have a patient on 5 drugs, the chances of them taking them all is pretty small. It's less than 50%. And so what you get is a lot of noise in those patients. Their blood pressure is highly variable. And what we saw at the primary endpoint of 6 months was that the treatment arm did have a blood pressure reduction of 14 points, but the sham arm had a fall of 12 points. And so there was a lot of discussion, well, does that mean the whole thing is just a placebo effect? The answer is no. So what happened in that trial? What happened is, because they were on 5 medicines and they weren't being tested for whether they were taking those medicines, they weren't even watched to take them. There was a lot of variability in medicine taking. The other thing is, patients were not supposed to change their medication prescriptions between the treatment, which was either renal denervation or sham, and the primary endpoint, because you only want to change one thing, right? You want to intervene on one thing, which is the renal sympathetic nerves or a placebo procedure. And then at 6 months, you see what's happened to the blood pressure. Well, unfortunately, what happened in 40% of the patients is they had their medications changed. And so what you've got is this sea of noise of intermittent adherence running into the study, and then you've got their procedure, and then you have changes in the medicines amplifying that variation. And so we've ended up with a wild sham arm of 12 points that is too much. The other thing we learned is that the renal sympathetic nerves do not run where we thought they did. So we've been studying renal nerves for thousands of years, but due to an anatomical fixation issue, it was thought that the proximal nerves were closer to the artery than they actually are. Now, for the ultrasound technology, that's not so much of a problem because it goes deep. But for the radiofrequency, it has to go more distally. So do you see how the nerves wrap around the artery down here? And that's easier for radiofrequency to get to because it's calibrated to go less deep than the ultrasound is. The ultrasound is calibrated for more proximal denervation and can get out to these nerves. And so that's why we don't need to go into the branches, but the radiofrequency device does. So just to hammer home this point, the problem with HTN3 was the sham arm. These are 7 published sham-controlled trials of renal denervation since. These are the blood pressure reductions in the sham arms, 0.5, 0.6, 1.6, 4.5, 3.1, 1.8, 2.9. Gives an average of around 2.5. In HTN3, it was 12. It's not plausible that 12 is a placebo effect. The placebo effect is around 2. So something went wrong in that trial, and it's now being corrected with their technology and with our technology. And this is what we call RDN 2.0, is the trial designs have changed to produce these sort of consistencies. It's highly predictable across the different measures in 506 patients in the pooled analysis we published in JAMA Cardiology. So it's effective, and hopefully I've convinced you that the blood pressure reduction is meaningful, because I've shown you what SALT does, I've shown you what the effect size is of small reductions in blood pressure. Now, is it safe? It's very safe, remarkably safe. Even I was surprised by this. I remember doing femoral access procedures 20 years ago when I started in interventional cardiology, and I switched to fully radial in 2006. And when I came back to it in TAVI. And so I've been using all the TAVI techniques I've learned in order to get better at femoral access for these procedures. And that's run across the trials. How much better we are at femoral access procedures. Remember, the BMI in this population was over 30, 31. Can you imagine 20 years ago, those of us who were around, a string of procedures, 500 procedures, with only one minor vascular complication when the patients were fully heparinized? I wouldn't have remembered that. And it just goes to show how much better we are at safe femoral access now. The next question that's often asked is it durable? Well, the primary endpoints of these studies was 2 months for the Radiance program. And then there's an older study called ACHIEVE, where it was looked at 3, 6, and 12. The ACHIEVE study didn't change meds, and it stays down nicely out to 1 year. In Radiance, we were asked to uptitrate the medicines, so that does clutter the noise a little, but you can see that there's stability of medications from 6 months onwards and stability of blood pressure reduction. So there's no signal of any loss of durability, and the science suggests it's highly unlikely that there'll be a durability problem. You can see here, this is in Radiance Trio. So blood pressure came down at 3 years by 14 points. Okay, that's on office. And the number of meds at the beginning was 3.9, and at 3 years was 3.7. So they're on the same number of meds, and their blood pressure's 14 points lower. So whatever we've done, we can congratulate ourselves. Baseline is when we flipped these patients from their usual meds onto a triple pill. So they were on an average of 3. And at 3 years, they were on 3.7. They then went back to their individual meds. So again, a very small change in medicines. But again, we've still got a very consistent signal of benefit on office blood pressure. So it does look like it's durable. The other advantage with the device is it's there all day, the so-called always-on effect. So some antihypertensive medicines, you take them and they start to wane during the night. And actually that's when you need them, because most cardiovascular events are in the early hours of the morning. But this has a full 24-hour effect. It may even be greater at night. If you look here, there's a signal, and this is across many trials, that the denervation effect may be bigger during the night. So does everyone get the same? Well, probably not. There's an apparent non-responder rate of around 30%, which is about the same as PCI for stable angina. It's a better response rate than AF ablation. It's a better response rate for symptoms than cardiac resynchronization therapy. And what we see is those with highest blood pressures get the biggest falls. We're not quite sure why those who don't respond fail to do so. I think it's probably not technical failure. I think probably what's happening is the other systems that control blood pressure upregulate in response to the drop in the sympathetic nervous system tone. There's a reason the brain wants higher blood pressure, and when you take out one mechanism of doing so, it just upregulates the other. I think that's what's happening in most of these cases. And that should encourage us to try again with drugs after denervation, because they may be more effective, although we wait for data on that. And this just emphasizes, it's a complicated graph, but I'll talk you through it. So on the left here, we have patients who started the trial with mild hypertension. So their ambulatory was between 135 and 145, so mild hypertension. What proportion of those got to control just with denervation? Maybe you could call it the silver bullet, right? They were asked to start medicines, and instead they were given a device treatment, and about 42% got to control with denervation. As you get more severe hypertension, it drops to 1 in 5 who get to control with denervation. And as you get to the severest group of hypertension, those with moderate to severe, then it goes up to about 1 in 10. Okay, so 1 in 10 who don't have to take pills because they get to control. That's not bad. It's not perfect, but it's not bad. It's the same as one drug. And down here, though, is what you see is the effect size in these groups. If you have mild hypertension, then there is a floor below which your body doesn't want that blood pressure to go. So it drops you by 6, but it won't let you go anymore. In medium hypertension, it's 8, and in severe hypertension, it's 10. And for this reason, we focused in the UK at the outset of renal denervation on more severe hypertension. We showed much bigger falls than this because we were taking patients with 170, 180, 190. And then you start to get 20-point reductions. And I'll have some data to show you on that in a second. But this brings in this concept of number needed to treat with this technology to get a favorable response. So if you call a favorable response more than 5 millimeters in ambulatory, which would be expected to have a significant impact on your cardiovascular outcomes, or get you to control. 2/3 did so with the Recor device. If you want to push the bar out further and say, okay, we'll have 10 on ambulatory blood pressure or control, it's 1 in 2. And then there's a small number in whom the noise of the control arm got there. So the number needed to treat to give someone a big effect, 10 millimeters on ambulatory is a big prognostic effect, or to get them to control such that they don't need any more medicines, is 3. So an NNT of 3 is not bad. It's not perfect. We'd like it to be 1, but it's not. It's 3. And this just emphasizes that some of these patients get very big drops. So we're quoting an average, but the average includes patients who don't respond. So if you're a responder, your average in the trio was a 17-point reduction in ambulatory pressure. This is life-changing. This is the equivalent of 2 drugs. That is a big effect for a lot of patients. But we don't know who they're going to be. That's the problem. We have to denervate 10 to have 7 have a response. And then 3 of these will get a huge response. We just can't tell who they are. And I don't think we're ever going to know who they are. Okay, so we've just got to denervate the 10 and accept that 7 will respond. AF ablation wishes they had numbers like that. And then again, some more data on longevity. This is the Leipzig experience, again showing blood pressure coming down from 150-odd to 140-odd on ambulatory, and then staying the same. Okay, so I'm gonna end with a case in a box. It's 3 minutes, and it just shows me doing a case. And it will show you how simple this is compared to some of the things that we do. Everyone who's an interventional cardiologist can be trained to do this. It's a 48-year-old male. He's got uncontrolled hypertension, quite significant uncontrolled hypertension. If this gentleman goes with these blood pressures for the next 10 years, he's got a significant risk of a cardiovascular event. He's already on good drugs, and he's tried spironolactone, and it gave him breasts, and he didn't like it, gynecomastia. And so he stopped taking it. It's a very reasonable reason to stop. So he enrolled in a clinical trial of ultrasound denervation. There's no sound, so I'll talk you through it. So I realize nobody here needs taught about vascular access, but I make no apologies about starting with it, because we need to be aiming for the bottom of the femoral head with a fluoro marker, and then we need to be aiming 1/3 of the way up the femoral head with our ultrasound marker and using a 4 French micropuncture in order to hopefully land at the junction of the bottom third and the middle third, exactly as I've managed there. And that wasn't an accident. That's 500 TAVIs, where I've learned exactly how to stick the spot I need to get in order to safely get vascular access. And that's the standard we need now for femoral access procedures like this. We then do an aortogram, and I've actually put the catheter exactly where it should be, which is the juncture of L1 and L2, but this patient's renals come off slightly above. You can just about see the ribs here. It's the 12th rib. So normally the renals are a little bit lower than they are. But anyway, I do subselective angiography with a 55-centimeter IMA catheter, and then we measure the renals. Now, I'm using the Sync Vision system. I'm slightly off screen down here. And you just do a click, and then it will give you the diameters. So this works most of the time as long as your arteries aren't too big. So you can see here that the renal artery is 7.2, which is great. We can treat 3.5 to 8 millimeters, so no problem. This is me flipping to the other side. And again, you can see how quick this is. Once I've done my first invasive angiogram, I want to do my other invasive angiogram just to check that the anatomy hasn't got any aberrancy, hasn't got severe atherosclerosis, hasn't got webs from fibromuscular dysplasia, and that I'm filling the whole kidney when I inject, and therefore I know I haven't missed an accessory artery on the aortogram. This is using not the Sync system, but using the X-ray system to measure it at 7.9, takes a couple of minutes, and therefore I know I can use an 8 millimeter balloon for both sides. This is me in real time advancing the Paradise device over the wire. I've just moved it a little bit, and then you inflate the balloon via the machine, and then you check that it's opposing the side. It's very low pressure, it's not injuring the endothelium. And then once we do, we've got the energy on, so you know when the energy's on because both my hands are on the patient's leg, because they get a little bit of warmth in the back, and they've got a bit of sedation on board, and sometimes they may kick out at the leg because they don't quite know what's going on with the warmth at the back. And that was it. I didn't shorten that. When it said energy on the screen, that's the 7 seconds of sonication it takes to deliver one of the energy deliveries with this device. How many deliveries do we have to do? 6 in total. So 42 seconds of discomfort. It's a very short amount of time. And you can see there I've got my hands on the legs just in case the patient gets excited and he's completely fine. This patient only had 2 milligrams of midazolam and 25 of fentanyl. I then switched to the other side. You can just draw it back into the catheter. So again, you don't need to take it all out and wash it. Wire the other renal, slide the device forward, and then bring it in. Make sure you keep the wire in the screen. Don't let it go off the screen because that's the risk of perforation. Just like with the coronary, you don't want the wire off the edge of the screen. And then you bring the device out. Check that you're not on a bifurcation point. Inflate it. 2 hands. Off we go. 7 seconds. Do it again. And then do it a 3rd time. And then angioseal and you're done. Skin to skin, 38 minutes. Patient had very little discomfort, although it can happen. They can get discomfort. But in this case, very little. And the patient went home the same day. They do not need to stay overnight because you're giving them quite light amounts of sedation. So we're studying this in 3,000 patients now, 200 sites, Global Paradise Registry, and that's going to give us the very large-scale data on top of the 506 patients we published in JAMA Cardiology. Who should we begin treating with? Those who have uncontrolled hypertension or resistant hypertension, and those who are intolerant or non-adherent to drugs are the ones who are slightly trickier. But resistant hypertension, uncontrolled despite best efforts, that's the group to start with. And that's what was said in our consensus statement. The ESH has recommended it for those who have hypertension despite 3 drugs and those who are uncontrolled where drugs cannot be tolerated. And that's a class 2 recommendation, okay? So we have now a major international hypertension guideline supporting us, as well as, I'm sure many of you have heard, the US FDA have approved this technology. It's now in clinical use in North America. It's now beginning in clinical use in Europe, thanks to the ESH guidance support for the first time. And what I would say is it's simple and safe if you're trained. So if you're going to start this, you can give a high degree of confidence to your patients that this is a safe procedure, but you need to be trained. And the expected effect size, the numbers of 30 points, they can be achieved if you take patients with blood pressures 200, 210. But the patients we studied had milder hypertension in the trials. For the effect size we got in that, you'd expect a reduction in the risk of stroke of around 28% and heart failure by 27%. That is well worth having. And if you take the more severe patients, you're going to be getting 15 to 20 point reductions like they showed in the Global Simplicity Registry and like we saw in the TRIO patients who were responders. Thanks very much.
Thank you, Dr. Sharm. I think what we'll do, we'll start with our discussant and start with Dr. Ahmad. I think the first question is, where do you see in Jordan the need for renal denervation therapy? Is the resistant hypertension and the uncontrolled population is the only group that you think, or there is a special unique characters for the patient in your practice?
Thank you very much, and thank you for giving me the chance to talk. First of all, I will share with you some of the unique things about Jordan, which is very common to all over the world. From our studies, we noticed that hypertension is the #1 cause related to cardiovascular diseases in Jordan, which is really reassuring that we have to treat this disease very aggressively. The second thing is that we did a study about adherence, which is very unique to Jordan, and we noticed that the adherence is less with the more severe hypertension. The patients, they need it more, actually, which gives us a chance that we really need to look for a global approach to hypertension, not only to the mild or the moderate, but also the severe hypertension. Beside that, we need to also preventive therapy. So just looking at this as an isolated therapy is not probably adequate to give us the best chance to control patients, but it has to be part of a global approach to treatment of hypertension.
Sure.
So if you look at it this way, you will find that there are a unique patient population that could benefit from these therapy. We have a lot of patients who refuse to take medications, even if they have mild to moderate hypertension. These group of patients that could benefit from therapies that proven to decrease the blood pressure, not only as a number, but also the consequence of hypertension, which is heart failure and mortality and so forth. And the other group of patients may be the resistant hypertension who are really, you maxed up your medication or they cannot tolerate more medications. So has to be based on a single approach to every single patient, as you mentioned.
Absolutely.
Those patients need a special approach. But I think that beyond that, if we look at procedural, everybody of us, intervention is moving to radial. And if we modify certain devices, we can go radial and do renal denervation, just longer guides that give us access to this therapy through a less invasive or more safe approach to renal denervation. So this is something that could be in the pipeline to think about this procedure to be more applicable and in line with the traditional thoughts of changing route of intervention.
Dr. Hassam, patient selection. Can you elaborate more what you think the process that we should follow for patient selection?
I mean, thank you again. It's for us as a nostalgia, actually. We did have the hype of RDN about 10 years ago, in which we did use the, as I recall, the St. Jude device at that time. And there was a big hype to do more of these cases, and we did. And I think you're alluding to is, and I'm actually very fascinated with the data that Dr. Sharp had showed us, is like there was a big hype, like anything else in interventional cardiology, and then it dipped really negatively, and then it's now resurfacing again with the endorsement of some of the international guidelines and FDA approval of this therapy. And then after that, and I think what damages in a way, in a negative way, of utilization of technology is the question that you're asking me today is, how do you use them? How do you pick those patients? And I think if we want to adopt the results that Dr. Sharp showed us, it has to be adopted with the trials that they have used. If you really have a steering committee in which really goes into, not everyone gets this, you go by the data that you have and you try to apply it to our local population. Minded that we also have, as we all know in hypertension scope, that genetics play a factor as well. So people maybe we are in the Middle East are different than the Europeans. The Europeans are different than North America. And the question would be really, does this data apply to us? And I wouldn't be able to answer that because, as you all know, who've been treating patients with hypertension, the variability is so intense. And to apply this to us, of course, the data is fantastic, is we have to, one, select the appropriate patients, two, and have your own local data in the Middle Eastern population, see if that is something also a viable option to us.
Sure. Dr. Arif, people still quoting HN3 and saying it was negative. What will be your response after the FDA approval last month?
Well, thank you very much. First of all, this is really reviving somebody from death again. So renal denervation has been revived. I'm glad to hear this. We have been also involved, as Hussam mentioned earlier, in the beginning of the era to use it. And the problem was we had really good results at that time as well. And I'm glad to hear that, Dr. Kurdi, you are still using it in that frequent matter, because we have noticed, we have observed some good reactions, responders. But then came the hypertension 3 trial, the bubble, as if it was a bubble. We were under shock. So what to do now? We are not supported anymore, and people will ask you more and more, and our people here are really also asking about the evidence and why you are using, as doctors came into controversies. Certainly this 7th of October, or November, as we say, showed us really, it made me feel comfortable again. I have some backup now, again, a support in the guidelines to go, and not only that, we have new technology with less time and with more efficacy, and with not only that, again, with even mild to moderate. If we look at the SOLO and the Adrian 2 trials, we are talking about 0 to 2 medications on board. So that was our aim in the beginning. could they be potentially candidates for our renal denervation? That was no. You have to look for a case with 4 or 5 that was really a challenge. So clinically said, when I was searching for patients, most of them were non-adherents, non-adherent to medication. So the problem was identifying those cases with very severe resistant hypertension was a big challenge. Though the results you have demonstrated kindly, Dr. Fisher, the responders are more with the resistant hypertension population. But now I have more wider spectrum of population that I can deal with, and including the non-adherent and intolerant to drugs, So we have more widened spectrum of indication, which makes me feel more enthusiastic a little bit toward using this technology again. And that doesn't cause pain, and a lot of new advantages in the new technology. So yes, I would go again and fight for this kind of technology. Thank you.
Dr. Fahd?
Well, I enjoyed this talk. I call it the kiss of life for this technology. So we are reviving technology that I think we were believing in it before, and we still believe in it more. In terms of hypertension, it's the silent killer. People get excited about COVID and everything, but I think hypertension is the silent killer, the #1 cause of cardiovascular disease. There is a problem of controlling it. There is a problem of diagnosing it, treating it, reaching the target. We saw all these numbers are really scary numbers. So we have to have a plan now. And I think our plan, it's yes, catheter-based technology. We talk about it among ourselves as interventional cardiologists, but the most important is we increase the awareness among the internist, nephrologist, cardiologist. So these people, they should be aware about this technology, that it does exist. Anyhow, for my patient, I used to say treatment of hypertension is 3 arms, triangle: diet, exercise, and medication. Mm-hmm. But from today, I will change to a square, adding to it renal denervation. Thank you.
Thank you. Professor, please.
Thank you very much. A couple of quick points. Number one is that everybody who graduates from medical school, and in England, even people who haven't graduated from medical school think they're hypertension experts and treat hypertension patients. So hypertension patients are not in the patient pool of interventional cardiologists. You're going to get massive resistance. So the way to go is to go and talk to nephrologists, to family physicians, to show them the science, because this is extremely important. Otherwise, we can believe in it as much as we want. We're not going to get enough patients. The second thing is related to Egypt, where I practice, and I'm actually involved in a national women hypertension project now. And probably, maybe the Arab world is a little bit similar, which is the biggest patient who's completely silent in Egypt with hypertension is women. Women are invisible in Egypt. Okay? They don't go to doctors unless something is drastically wrong. They don't go to screening programs. Their blood pressure is not measured. And when it's measured, we're a very conservative society, so she's wearing 4 layers of clothes. She rolls up her sleeve halfway, and some ridiculous measurement is made, which is inaccurate. And then they only come with complications of hypertension. So we have to see programs and put programs in place where we can actually find the women, take their blood pressure, convince those of them who need treatment that they actually need it. Because many people will say, oh, no, yesterday I had an argument with my sister, and today my blood pressure is normally low, because they think of themselves when they were 15, when it was low. So the patients, the opportunity is huge, but it is lost. Mm-hmm. And if we're going to start denervating kidneys, let us put a comprehensive program. Let's put it together where we can, because there are millions of patients out there. And please, one final remark. Think of renal denervation as a pill that you're going to take only once, which doesn't cause any side effects, which is going to make your blood pressure slightly less and slightly more easier to control. Because if we increase the expectations in the community, we will get disappointed. Thank you.
Thank you. Please.
If we have time for a question. So one of them is optional since we're short on time. But just a question to Dr. Sharp. How would you treat patients with resistant hypertension and CKD, which is often a accompanying comorbidity, differently in your technique? The incidence of CIN, is that a concern? The other thing, it's clear that the neurobiology aspect of hypertension is established here. And you said also that, frustratingly, there are no good predictors for who's going to respond or not. Has anyone looked at the variation in circadian variation in blood pressure, like when someone is asleep? Does that equivalent kind of to like kind of a renal denervation trial? And is this something that you looked at in your database?
Yeah, both great questions. In terms of predictors, we've looked at everything. I mean, everything. Nocturnal heart rate, nocturnal blood pressure, speed of dip, magnitude of dip, onset of dip, everything. And we can't find a predictable one that's reproducible. Heart rate has been reproduced once, i.e. 2 trials have shown that if you start with a high heart rate, you may have more sympathetic nervous activity and therefore you may respond better. But it's not a strong predictor, i.e. you can't use it to rule out or rule in. It's just a cofactor in your decision. The next question is renal function. So we've studied people in these major trials down to an eGFR of 40, 45, depending on which device and which trial. We've not seen any adverse effects. You can do this procedure, particularly the one I've just shown you, with about 10 mils of contrast if you want to. And you're not going to harm anybody with a GFR of 40, 45 with 10 mils of contrast. I've got colleagues who are doing it with CO2 angiography, who've done procedures with no contrast. But I don't think it's necessary. I think you can do these with very minimal contrast. The risk to kidneys, actually, we need to invert the mindset. So, as you know, hypertension is an accelerant of kidney decline. So if you've got anything wrong with your kidneys, hypertension makes it nosedive faster. And so what we're seeing in the trials is that the patients with normal kidneys, their blood pressure drifts down with age, as it does in everybody. The patients with kidney impairment, it's staying curiously flat. And it may be because we're removing that accelerant of hypertension. Now, as Hani said, it's definitely not a silver bullet. It's part of a package. But reducing blood pressure protects kidneys in the long term, as long as we do the procedures well.
Thank you.
I actually have a clinical poster that I published for 30 patients showing an improvement in GFR after renal denervation. So if that's answered your question.
I have 2 questions, very quick questions. The first one is how to confirm that you did the ablation, because the sympathectomy showed marked reduction of blood pressure, while the catheter-based, when you decrease it by 5 millimeter per mercury, you get this is success. Yep. But when you do surgical sympathectomy, you take it markedly down. So is there any confirmatory test? And I think the sympathectomy really is effective if we do it sufficiently.
Yes, so both great questions. Firstly, surgical sympathectomy doesn't just affect the sympathetic nerves, as you know, sometimes it affects other things. Now, when we were doing it in the gut, we were also causing abnormal venous pooling in the gut. So that's why the surgical procedure caused lots of side effects, because they were manipulating lots of other things. Predictors, there is no good predictor. We think we don't need one, because in the animal models, over 90% of animals treated are getting full denervation with redundancy. So the reason we do 3 sonications on each side with this device, we only really need to do 1, maybe 2, is we're building in redundancy to make sure that we're adequately getting those nerves as they oscillate in their distance from the renal artery. So the non-responders in an animal model are not very likely to have a blood pressure reduction in response to a second procedure. And that makes me think we got it the first time. And the reason that they haven't responded is that there's something else driving their hypertension, which makes sense. There's many systems that control blood pressure. So people are continuing to look for something to prove we've done the procedure right. But the bench work suggests that we have. And the response rates seem to be consistent across all the devices of around 70%. And that might be just because there's 20% out there who will then upregulate their renin levels, their aldosterone, their baroreceptor activity, and all these other systems that make the brain get what it wants. The brain demands high blood pressure. And when you cut off one response, in some people, it finds another way, is my view.
Yeah.
Thank you for such a great session, but I have two questions. First one, in the study, the studies you presented, there was patients who were on a single pill, and there was 42% of them had can stop their medication. So that means that we can include this kind of patients. How did you include this kind of patients in your trial?
Yeah, so it's a great question. I'm sorry if I didn't make it clear enough. So when they came into the study, the off-med studies, they were on between 0 and 2 pills. We then took them off all their medicines, waited for the blood pressure to stabilize, and then we denervated them or we put them through a sham. And what we showed is that in those patients at 2 months, this is 2 months data, bear in mind, that blood pressure came down if you had mild hypertension into the desired normal range in about 42% of patients. What happens to them as time goes on, we've still got to see, right? So I am not saying that we should take mild hypertension, take them off their drugs, denervate them, and tell them they don't need pills anymore. What I was trying to explain is what is the impact of denervation in the different severity groups. Mild hypertension, it brings you into control at about 42% of the time, but you only get 6 points of ambulatory reduction. Severe hypertension, it brings you into the range 10% of the time, but it gives you a much bigger effect size. So who should we treat? In my view, it should be resistant patients and patients who are intolerant. There are millions of them.
Yes, that's because these are some, we face this kind of patients who are mild hypertension, systolic blood pressure less than 150 or 145, and they are resistant taking medications.
Yeah,
and they are not compliant, and we leave them until they have the complications.
Yes.
And I think there's a place here. Yes. Did you ever, any of these, in these, your cases, you have repeated the procedure?
No, there's very few procedures reported. I think the largest case series is 12. And of those, about 4 out of the 12 had a significant blood pressure response in the second case. But there was doubts about the first case. So accessory arteries we didn't talk about. 100%. We can do accessory arteries for 3.5 millimeters, but not below.
I think for the sake of time, our discussant, they have another session, so they had to go. So I'd like to thank everybody. I think the summary here, or the take-home message, is that renal denervation is back, and it's back with different technology. I've been with the basket therapy at its initiation, and I was the proctor, by the way, who started in Bahrain. Yes. So, we were very excited of the basket technology. The catheter or the spiral technology is the alternative, and now we have the balloon with the ultrasound technology, which is all FDA approved. I think it's time for us to support our patient and educate them, make them aware that there is more options. There is nothing called status quo. And yes, this is my blood pressure. It's we need to fix the high blood pressure, and we need to support our patient. And as Dr. Sharp clearly said, that 5 millimeter reduction will translate into a significant reduction on cardiovascular and stroke reduction for our patients. I thank you all for being here today, and I wish you a good afternoon.